So can you see my
Yes, we can see it. Yeah. If you just go into slide view.
Excellent. So I've just set the clock running because we have 10 minutes each. So thank you again for inviting us here to speak on the topic of the use of technology in healthcare. And I think essentially this is where we want to get to at the end, is that the patient will see you now rather than the way it has been traditionally, where the clinician sees you. And this is what I'm going to cover over the next 8 minutes or so. So what is driving the change? Well, apart from the obvious, which is the pandemics that I have at the bottom, there are other reasons, which is patients are a lot more informed than they have been at any time in the past due to the internet, but also due to the concern they have for their own conditions. There are more and more chronic conditions, especially in the first world countries. And also healthcare facilities and hospitals are trying to reduce the number of days that people are required to stay in hospital. And to do that, we need to have much more remote care for patients. So the journey that we got to where we are today is it started back in 2003, where the Haemophilia services became the first service in Ireland to have a national electronic health record. So what that means is moving from a paper-based system to a digital system where patients' notes, diagnosis, treatment of choice, etc., are all recorded and shared electronically. And then after that, we moved to the scheduled delivery of service for CFCs based on the gold standard for track and trace, which is called GS1 standards. And then in 2010, we implemented a smartphone medication scanning app, which was the first in the world and still is the first in the world, as far as we're aware, to use barcode scanning in the patient's home in order to track and trace and to record compliance and to monitor stock. So what's new? Well, in 2017, we were invited by the HSE to become one of 3 Lighthouse projects in order to demonstrate further enhancements to the service that we provide that could be used and drawn upon by other services within the HSE, and that's why they were called Lighthouse projects. So what that has allowed us to do is to have a complete refresh of our electronic health record. We're also doing a complete refresh of the scanning app, but most importantly is we're developing what's called a patient portal, which I'll go into later, which will allow patients access to their medical records 24 hours a day. And then what's come to the fore due to the pandemic in particular, and Niamh will talk to this in particular, is tele and video consultations and how they're transforming how we deliver care to patients. So just a quick recap of the scanning app. We would like to encourage all of you to use the scanning app where and if possible for a number of reasons. And we'd like you to scan your medication before you take it, because it performs some very important safety checks. It checks that it is your prescription, it checks your medication is in date, and it checks that it's not on a recall list. So they're very important checks for yourselves as patients, but also for us as healthcare providers. It allows us to gather information on your bleeds, the nature of your bleeds, the frequency of your bleeds, and that forms part of your electronic health record. So when you go into your doctor, they have that information available because the app is integrated into the EHR or electronic health record. And the other reason why you really need to do this check is that if you don't, Evelyn Singleton could be knocking on your door, and nobody would really want that. So I think it's very important that you do scan, but really it is for your patient safety. So we are working towards a new version of the app. It'll have a new look and feel. There'll be better stock information for you to look at and to manage. There'll also be a specific function that allow Haemophilia patients to record where they are injecting themselves so that they can rotate the injection site. We're also hoping to have a body diagram instead of the drop-down menu, so that you can record what part of the body you're actually having the bleed on. Now, we were looking for models for that body diagram. So if Shay and Michael are listening, we don't need you guys. So thanks very much anyway for offering. And also we're hoping to have a patient diary so that you'll be able to have a record of what your treatment history was, but also when your upcoming infusions are, to have a better handle on that. So patient portal is the big thing that we're hoping to roll out this year. And as you can see in the screen, it tells you what exactly it is. So essentially, it will allow you as a patient direct access to your own health information as it's stored on the electronic health record. So you'll be seeing exactly what the healthcare provider and what the laboratory results are posted for you. So you'll be able to access that anywhere 24 hours a day. We would hope to, in time, include some of the features that you see here, such as your upcoming appointments, if your treatment center uses that. You'll be able to hopefully integrate it with your wearable devices, such as your Fitbits. And also, with the help of the IHS, we'd be able to include some educational material on that patient portal. So what will it look like? Well, it'll be available on a laptop or PC, but also on iOS and Android. And Valentia, who are our electronic health care record providers, are providing the patient portal as well. So this is what it will look like when you're logging on. And once you do log on, then you will see a number of tiles that will contain information on your care. And that's an example there of, in time, what we hope will be available for you, including appointments, medications, immunizations. Now, it's important to stress that patient portals are in essence, they're connected to a single EHR. So patients with multiple comorbidities who might be under different services, they only will have a patient portal at the minute for whatever service is providing it. It's not going to be a cradle to grave for all your conditions. So here's how you'll be able to sign up. We will be inviting, it's going to be a soft launch. So we're going to invite some patients who are part of the focus group to get this up and running. And you'll be able to sign up by email, post, or during a visit to your coagulation department. We will ask for some proof of identity, and that is required by law. And there will be a patient information leaflet to tell you what is required. So you will require an email address, and once you sign up, then it will be like online banking or other services where you will receive a link and then a one-time password, and then you will set up your own password after that. So what's needed? Well, we needed to have an EHR in order to give you information on your portal, but also generally any service that provides a portal needs government backing. So we've had the HSE who are backing us here, but also the coagulation services themselves and yourselves, and also the individual hospital. Clinical engagement is also very important, because this is a new step for clinicians, because all your letters, all your notes, anything that has been written about you or for you that's in your chart will be available to you. And also results, your laboratory results are available. So clinicians are naturally nervous that they want to make sure that you're not getting results that may not necessarily alarm you, but you may be concerned about, and they want to make sure that they have sight of them, and that they will have the answers for you if and when you need to contact them. Also, you need to be able to integrate the patient portal with other services that I've talked about. And we also need ongoing funding, which we will have to look for from within the hospital to keep this going. What information will you have access to? Well, essentially, in time, we would hope you'd have access to all your information, but we're going to start with immunizations, your letters, appointments, if they're made through the EHR, and then also some links to your local hospitals facilities. In theory, you can use this as a health vault. Now we're coming up with some difficulties, I should say, with data protection, to make sure that if we store your data on your behalf, where is it stored, how is it stored, how are you going to have access to it? So we have to work through all those before we can give you access to that or allow you to do that. It is secure. We have performed extensive testing on it to make sure that it can't be hacked. But again, we're working with each hospital's data protection officers to make sure that all the information is secure and and can't be hacked by somebody else. So these are some of the issues that we're coming up against to make sure that your information is secure, make sure that the information is valid. So if you load your own information, it doesn't become part of your EHR, but it is there for your own use, such as your own GP letters or some information you may upload yourself from Fitbits. And also we want to make sure that if we do provide links to other sources, that they are validated as well. So that's really all. It's a whistle-stop tour, and I'm going to hand over to Niamh now, who's going to talk on the next part of this presentation.
Thank you.
Good afternoon, everybody, and thank you so much for inviting me to participate in this AGM of 2021 for the Irish Haemophilia Society. It's a really important time in our calendar for all of us, both and the treating community and yourselves as well, I know, and it's a great opportunity for us to see what's been happening over the past 12 months and to make plans for the future. Obviously, the past 12 months were very different to what we had originally anticipated this time last year. It was really the beginning of everything at the AGM last year when things began to declare themselves as being a very changed environment to what we had been used to before. But nonetheless, I think despite of all of the challenges of the last 12 months, I think there are some positives too. And I think we as a community, patients and treaters, have managed to come through pretty well, I believe. And part of my discussions today will be focused on some of the benefits we've managed to leverage out of this bad situation, and some of the things we'll want to be keeping as we go forward, and maybe some of the older ways of working that maybe we want to try and incorporate as well. So telehealth in general is around delivering healthcare remotely using telecommunications technology. And it can be used for things like assessing people and monitoring people. And this we would call clinical telemedicine. Or it can be used for educational purposes like this webinar, or in educating ourselves as a healthcare team, or in communicating with people who attend our service. So there's lots of different ways in which we can use technology to support what we're trying to do to help people who have bleeding disorders. I started in haematology in an outpatient clinic way back in July 1995. And the setup at the time actually was very similar to this. So there was a table in between the clinical team and the patient, so certainly a barrier there. There was no technology of any description. It was all paper, and it was very much all face-to-face. The waiting area would have looked something like this, rows of people all together waiting to be called, and sometimes for hours on end. Fast forwarding then to 2020, and this is a picture actually from just before the pandemic hit from St. James's. This is one of our dietitians. So what's changed, of course, in the intervening time is that she now has a computer, and there's some digital equipment in the background, but she's still using pen and paper, and there's still a desk, albeit that it's not between her and the patient anymore. And the waiting area was still pretty much the same, and that was, very, very recently. You all are using very different mobile technology devices to the ones that you would have used in 1995. I remember my first mobile phone, which I got in 1995, and it was a very different beast to the smartphone I'm currently using. And on that smartphone, I can now do things that I never thought would be safe or possible, like online banking or ordering random items from websites in lieu of being able to go to Dundrum Shopping Centre. And we use it for healthcare purposes. So, you know, we have a COVID tracker now, for example, that's a part of our country's response to the COVID pandemic. And there are lots of different apps and devices that can monitor health parameters and might be able to detect an irregular heart rate, for example, or allow your doctor or healthcare team to have a look at that. So society and technology have moved on together. Hospitals have been doing some work in the area of telehealth, mainly in outpatient settings for chronic health conditions such as things like diabetes, cancer and heart failure. And they tend to be people with chronic, fairly stable conditions, having routine follow-up. And it's about things like discussing results or confirming that people remained well. But the events of the last 12 months really have changed that, so that even now people who have an acute issue, depending on the actual issue it is, could benefit from a remote assessment first before deciding whether they would need to be seen in person and where in the hospital would be the best place to see them. You know, we've had some information already, even going back to 2016, that teleconsultations can be used in pediatric patients or children with haemophilia and bleeding disorders. And this was for acute bleeds. And then Dr. Kulkarni published a nice paper in 2017 looking at a central comprehensive care centre and the interactions with more remote hospitals closer to where the patients were living, but giving the specialist comprehensive care input into the care of those patients. And we've also had lots of experience over the years with you know, various devices, websites and apps to monitor treatments. And there's a number of those, and they've been summarized in a clinical study. And then more recently, we've had a number of reports of management of bleeding disorder services throughout the pandemic, a couple from Spain, looking at clinical trials in haemophilia and also orthopedic surgery in one patient, and then a couple of reports from China. And I'll share with you in a minute our own experience here in Ireland. So in April 2020, we were lucky here in James's to be able to access a secure video streaming system whereby we could have a normal, confidential clinical consultation with a patient that was provided by our hospital and where it was validated for use for a medical consultation. And, you know, having that secure system was really critical, because if we didn't have that, I wouldn't have been comfortable really to use one of the commercial platforms, which are fine for your family WhatsApp app quiz, but really not secure enough, I think, for a medical consultation in my view. But having had the provision of this Blue Eye service, we were able to really use it across our whole multidisciplinary team, including physio, dental, psychology, our medical clinic, and also our nursing colleagues, in particular our ANP, Niamh Larkin. So the setup is very much like this. You know, we have our main computer screen open, which has our electronic health record and our blood results and all that sort of thing. And then we, typically I would have a smaller screen where I have the patient visible. We were able to put together our experiences quickly and had that published in Haemophilia, initially electronically in September and then later in the journal in November. And what we found during the COVID pandemic was that while we had to rapidly close down our service almost immediately in early March, and you can see there in the red bars that the 2020 numbers for the month of March were quite a bit lower than they had been in the previous year. But by April, they'd recovered almost to where we had been the previous year. And by May, thanks in particular to our clinical research fellow, Dr. Murray O'Donovan's efforts to assist us, we were able to actually increase our workload in comparison to 2019 and make up the backlog, I suppose, that we'd lost in March and April. In St. James's, you can see that in the red line here, there was a massive fall off in the outpatient clinics through March, April and May. And these are the face-to-face outpatient clinics. But if we look at including telemedicine and outreach clinics, you can see that while the dotted red line shows the face-to-face clinics, the heavy red line shows all of the clinics, so that there was, if you like, a preservation, relatively speaking, of at least some of the activity. And that was all down to telemedicine, really. As you can see, there was a big uplift in the number of telemedicine consultations. So it's amazing how rapidly this was adopted, I think, by our healthcare community and our patients. The rapidity of it was astounding, but it goes to show what can be done when we need to. We wanted to make sure that people who were experiencing telehealth had, you know, an opportunity to give us their feedback, and they did that in a survey that I'm very thankful to everyone who participated in. Very much a positive response from patients, outlining that they were pleased that they had better access to clinics, that they didn't have to travel, and yet their healthcare needs and communication with their healthcare providers was possible. So I think that was very reassuring for us, albeit that we take the point that this was a survey we did in the midst of the pandemic, when obviously people were very aware of the risks of coming into the hospital, and therefore any telehealth experience naturally seems to be measured against that risk. Our healthcare providers also had a very good experience with it, and in particular, I think the video consultation was found to be really easy to use in terms of communicating with the people that were being reviewed. And importantly, I think at the time, at least anyway, not being able to do a blood test didn't seem to be a concern for people. Although, you know, it's as the pandemic restrictions go on in time, we do have a little concern, I think, about the potential for missed healthcare because of not being able to bring people in. One very big benefit, I think, was that we had a non-attendance rate of 10 to 15% chronically for the last at least 10 years. And we couldn't, no matter what we did, we couldn't change it or improve it. And, you know, it's because it's very inconvenient sometimes to come in a long distance to a central hospital to have your clinic appointment, and things crop up that mean that people can't come. But the non-attendances have really gone away almost entirely with telehealth, and that has been seen initially, but also persisted throughout the rest of the 2020 and into 2021. And I think that's really good, because we feel that, again, that we're not missing healthcare opportunities because of non-attendance. These are kind of my own sort of views on video consultation. It's an interaction I like. I must say I do enjoy the video consults, and I find them very similar to a face-to-face consultation. Those who are hard of hearing, if they do lip read, have that opportunity. We can include a trusted third person either with the person in the room, or now we have an opportunity to patch somebody into the consultation by video if we want someone to be part of consultation. And I feel it's reassuring for patients to be able to see me when they're discussing healthcare questions and advice with me. But I do find that I have to spend a little bit of time making sure the person is set up, can hear me and can see me. And there's no doubt that you must have good internet access. So if you have other streaming going on in the house at the time, it may not work. And sometimes we have to revert to telephone because it won't work. On our side, on the healthcare team side, we do need to organise our clinics to try and make that flow work for people entering the clinic, being seen, and then getting whatever actions at the end of clinic are needed, like a new appointment or a blood test or whatever is needed. And our team need training and support to do that. You know, we see that there are minor technical breakdowns during video consultations that don't, to be honest, cause a big problem. So if it takes a few minutes to get the audio working, that's fine. And if the screen freezes temporarily, it normally doesn't make that much of a difference. And I'm happy to repeat myself if I need to. But what really causes a problem is if we don't manage to get the connection. And certainly at the moment, I personally don't have a lot of knowledge about how to troubleshoot that. And so we always need to have a contingency plan, such as a telephone option, if the video doesn't work. So some tech support would be good, I think, for this type of consultation for the future. And on the side of making sure that people have good internet, I suppose we have to rely on our government, who have a plan, allegedly, which recognises that really at this stage in this world, that broadband is a utility that is absolutely required for everybody. And I know there are many areas around the country that just don't have reliable broadband. But earlier this year, there was some good news that the first homes who were being connected to fibre broadband had been connected. So I think that's very positive. Our clinics generally in the past have been organised according to the physical presence of the patient. So now we need them to be organised around the virtual presence of the patient. So, you know, there's a bit of work for us to do around making sure that we can configure our administrative team to be able to know which kind of consult people are having, and then being able to communicate electronically as well as by paper format with people. It's really about managing the entry of the patient into the clinic and their journey through the clinic, even when that is completely virtual. So at this stage, we are using telehealth across the board in every discipline of our service, be that telephone or video. We are also using other means of communication, such as email and other communications through, for example, the IHS, to make sure that our patient community is updated on developments as time is going on in the pandemic. And we're using things like video webinars and WhatsApp and email to continue our tele-twinning connections with our colleagues in Jordan. The future, I believe, is a hybrid version of telehealth and face-to-face according to the needs of each person. It's not one or the other. I firmly believe that if we do have consultations of any kind, honestly, I think people should have their information by letter or electronically, hopefully, but through the patient portal. And I'd hope that we would make some progress this year on integrating video consultation into our overall EHR, which might help to streamline some of our operational issues. My colleague, Dr. Santiago Bonanad, did up this schema and presented it at EHAD, and I thought it was really good because I think it encapsulates the things that we already have, such as treatment tracking and adherence, but other things that we think are very important around interpreting some of the information we're getting from patients around activity, bleeds, factor levels, if we can put in their PK and dosing, and also well-being. But it needs to be real time, as we have here in Ireland, otherwise it's fairly useless. Professor Pivandi earlier this week mentioned the idea that we should be able to capture our real world data in a harmonized way and connect to other databases, and I very much support that. We need to be able to collect information no matter what product people are on, and 100% we need to be sure that our devices and data are secure and private. So also at EHAD, Lucian Englund mentioned the 4Ds in relation to promotion of health, as he called it, rather than maybe healthcare for disease. And he was talking about democratization, in other words, accessibility really of health and health preservation and promotion for everybody, no matter where they are located. And the idea that this is delocalized, it doesn't have to be in a clinic in your area, that it could potentially be at some distance from you, and even potentially not even in your country sometimes, that it certainly will be digital, and it already is actually. So we're moving further and further away from paper as time goes on. There is, I think, a philosophical question about who pays for it and who benefits from it, because I think for sure in other countries, at least, who have a sort of a less socialized model of healthcare, there'll be people who make plenty of money from the digital healthcare revolution that's going on. I'd finally like to very much thank everybody who has supported us here in the clinical teams in relation to the Lighthouse Project, the pandemic, and in particular to the Haemophilia Society, who have been absolutely supportive of this project from the very beginning. Thank you.